Hello, today the topic of the lecture is adrenergic drugs. So we are going to discuss the biological active substances which can affect on adrenal receptors or the accumulation of adrenaline, noradrenaline, and actually all the drugs will somehow affect on sympathetic nervous system. I hope that everybody remember what is it. And let's revise a little bit information from the last lecture, from the previous lecture. So we have the three parts of efferent innervation, which are sympathetic nervous system, parasympathetic nervous system, and the somatic system. If somatic system controls the skeletal muscles and only has one neuron which goes from CNS directly to the skeletal muscle. I'm now talking about this part, if you are understanding. Yes, so here it's CNS, and from CNS the signal goes directly to the target cell, to the skeletal muscle. So the sympathetic and parasympathetic system, they are a little bit more complicated, as they have two neurons, preganglion neuron and postganglion neuron. Here also preganglion neuron and then postganglion neuron. So in sympathetic system, what is special about that is that the transmission happens not only with acetylcholine but also with noradrenaline. Noradrenaline here in the postganglion neuron transmission to the target organ, to the target cell. So here, everywhere you can see only acetylcholine, 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 and here also acetylcholine. But only in this place, in the second neuron connection to the target cell in sympathetic system, we have norepinephrine transmission. Okay. What about the adrenergic synapse itself? Let's look at our neuron. So we have the cell body of the neuron, after which it has the long axon, in the end of which there are some so-called structures, terminal varicocytes. Which are these varicocytes? They are like thickening, not thickening, but if the axon was thin, quite thin, so in one place there is much more space inside for this process of synthesis and deposition of the noradrenaline. So now let's see how this happens. Firstly, norepinephrine is synthesized from the enzyme, from the amino acid called tyrosine, which is affected by the special enzyme tyrosine hydroxylase, tyrosine hydroxylase. So, which converts this tyrosine hydroxylase into the L-DOPA, and then it will be converted into deoxyphenylalanine, which after that will be converted into norepinephrine. Norepinephrine is the final product of the synthesis in the neuron. After that, norepinephrine can be also converted into epinephrine. You remember, yes, that except norepinephrine, we also have norepinephrine, we have also epinephrine. And this is and this epinephrine, it has almost the same structure of norepinephrine, but in this norepinephrine we have one more extra methyl group, CH3, and in epinephrine it disappears. Okay, so now let's go back to our norepinephrine. What happens after the synthesis of norepinephrine? It will be stored in this deposition site in the vesicule inside the neuron. When the neuron will be stimulated somehow from the CNS, maybe there will be stimulation or somewhere on the way, so doesn't matter. Anyway, when the neuron is stimulated, many calcium ions will go inside this neuron. So this influx of calcium ions can stimulate the norepinephrine to be released from the vesicle to outside the cell. So it goes out the cell, which provokes the stimulation of the norepinephrine sensitive receptors on the target cell. So you can see here that norepinephrine goes out here and it can attach to the receptors. So then it matters what is the type of effector cell. Some effector cells, they have alpha-1 receptors, some have beta receptors, some have alpha-2 receptors. Doesn't matter. Norepinephrine can attach to these receptors. If it can attach to receptors, then they will be stimulated and we will have some effect. I will write here. So we will have some effects of these receptors. We will later talk about that, what can be the effects of those receptors. Okay, what also can be? Also norepinephrine, when it goes out from the cell, it can also undergo the reuptake back to this neuron, or it can be the uptake by the effector cells. And if this process of uptake happens, then norepinephrine will be destroyed. Why? For example, if it goes here in the effector cell, there is a special enzyme, catechol orthomethyltransferase. Catechol orthomethyltransferase enzyme, which will destroy this norepinephrine convert norepinephrine into normetanephrine. Then, if it goes to the, if it goes back by reuptake back to the sympathetic nerve, then it will be destroyed by MAO enzyme, monoamine oxidase enzyme. Monoamine oxidase enzyme will make the deamination of this norepinephrine, and deaminated metabolites then will be eliminated from the cell to the outer space. Okay, so this is what can happen with norepinephrine when it goes out from this vesicle to the synaptic cleft. Also, what can they make? They can stimulate, norepinephrine can stimulate the receptors not on the effector cell, but on the synaptic, presynaptic membrane. So you see, back on the cell from which it goes. If norepinephrine will attach to the alpha-2 receptors of presynaptic membrane, it will stop the release. You can see the minus, it's the inhibition. So these receptors are responsible for inhibition of the release of norepinephrine. So it helps us, why do we need that? Because it helps us to prevent too much release of norepinephrine. So we can stop it. Okay, and as I promised, we will talk about the effects which different types of adrenergic receptors can make. So First type of adrenergic receptors is alpha-1 adrenal receptor. They are located in the vessels, predominantly, which leads to the contraction of blood vessels, and it, of course, increases the blood pressure. Then, in the spleen, we have those receptors which leads to stimulation of them, leads to contraction. In the pupil dilator, we can have these alpha-1 receptors, which leads to contraction of this muscle, but the pupil will be bigger. Yes, I hope that everybody understands why, or if maybe you don't understand, I will make a picture for you. So in this pupil, we have like pupil here inside, and this muscle, which is dilator muscle, if we contract this muscle, what happens? Actually, it makes the movement like that from here to the sides. The muscles will contract, and finally, what will be the result? The result will be that the pupil will become bigger. The pupil becomes bigger because the muscle contracts and makes this. This is called mydriasis. Okay, also in the liver we have these receptors, and by stimulation of them, we have stimulated glycogenolysis. So glycogen will be destroyed. Then second type of adrenal receptors is alpha-2 adrenal receptors. They are located in presynaptic membrane of the adrenergic synapse, which we just saw in the previous picture. I can show you once again. Here, yes, in the presynaptic membrane, we have alpha-2 adrenal receptors, yes? And the function is to reduce the release of catecholamines. Catecholamines, in this case, norepinephrine. Sorry. We also have the central nervous system and exactly the inhibiting cells of the vasomotor center. And by stimulating of these inhibiting cells, you see that stimulating of inhibiting cells. So the effect will be inhibition. Nevertheless, we stimulate because this is the function of the cells. It will reduce the effect of noradrenaline because the noradrenaline is the absolutely stimulating neurotransmitter. And if the cells are inhibiting, so they will be like given the opposite effect. How that works? In the CNS, exactly in vasomotor center, there is a function of increasing the tone of vessels, increasing the tone pressure in the vessels. But it can be stimulated by noradrenaline. But if it works on the alpha-2 receptors, or the drug directly stimulates the alpha-2 receptors, so it will be no stimulating effect, and it will be no effect on increasing the tone of the vessels. Understandable? I hope yes. Okay, next. We have next beta-1 adrenal receptors. They are very interesting because they have a very pronounced effect in many sites, and especially they really affect on the blood pressure. Why? Because the first application site is myocardium, which increases the heartbeat, increases the heart rate and the contractions of the heart. So it stimulates the heart in many ways. Liver. In the liver, beta-1 receptors will stimulation will stimulate glycogenolysis. Again, the glycogen will be destroyed with making energy for us. Yes. In skeletal muscles, the same. Again, for making energy for the skeletal muscles to use. And in the central nervous system, also there is an effect, as we just discussed about the tone of vessels. Yes, tone of vessels will be controlled by the central nervous system, the vasomotor center. And in case of stimulating of beta receptors, it will be not the inhibition, and now it will be activation. So the dose will be increased very much. Okay, next. In the arterioles, vessels of vital organs, we have the beta 2 receptors. Beta 2 receptors, unlike alpha 1 and beta 1 receptors, they are relaxing receptors. You can write it down that beta 2 it's always for relaxing. And here you will find this answer in the table, that it actually gives us relaxation everywhere. If we're talking about beta 2 receptors in arterioles, it will be relaxation and increased blood flow. If we're talking about bronchi, it will be relaxation, which can be used, by the way, for bronchial asthma. In uterus, we also have reducing contractility, which can be useful in case of pregnancy. Adipose tissue, we have increased lipolysis, the only one not relaxing but activating, and in pancreas also. And in the synaptic membrane, we increase the permeability of the presynaptic membrane. Remember what we talked about presynaptic? We have alpha 2 receptors, which stops the permeability of this membrane for the catecholamines. And we also have beta 1 receptors, which increases the permeability of this presynaptic membrane for the catecholamines. And also in the juxtaglomerular apparatus, which is in kidney, we have all these types of receptors, beta 1, beta 2, beta 3. Stimulation of these juxtaglomerular cells increases the renin release, and this increased renin release will then affect on the blood pressure, which is very important for us because renin will stimulate the angiotensin to be converted into angiotensinogen into angiotensin, and angiotensin will have a powerful effect on the tone of blood vessels, which finally will increase the tone of the blood vessels, and blood pressure will increase. Adipose tissue can be also affected by beta 3, beta 2 receptors, which stimulates the lipolysis and thermogenesis in adipose tissue. Okay. And now about the catecholamines, which are norepinephrine and adrenaline. What is the difference between norepinephrine, epinephrine, noradrenaline, adrenaline? What is the difference between them? Norepinephrine is the mediator, which is synthesized in the vesicles of the adrenergic synapse, which I showed you, yes, in the nerve. In the nerve they are synthesized, norepinephrine, and it carries out the synaptic transmission. So this is all connected to the nervous system, yes, nervous system. And adrenaline, or epinephrine we can call it, it's the hormone produced in the adrenal medulla and secreted into the blood. See the difference? This is a hormone, this is a mediator, neurotransmitter. This is in CNS, this is in the blood. So this is our main difference in the blood and CNS. Also in the structure, as I showed you, as I told you before, there is a little bit difference with one extra methyl in norepinephrine and without in the epinephrine. Let's look at this structure about this methyl. That what the structure is the same, and one only difference is this methyl. In norepinephrine we don't have, in epinephrine nabrot we don't have it. In norepinephrine we don't have it, and in epinephrine we have it. So no, stop. Yes, in epinephrine we have it, and in norepinephrine we don't have it. So this is the structural difference, and also which we just discussed the just 1 second, adrenaline, which is hormone, and noradrenaline, norepinephrine, which is neurotransmitter or mediator, also we can say. So this is located in the nerves, and this is in the blood. Okay, and for your clear understanding, the structure of all the drugs should be quite similar to these natural stimulants of the adrenal receptor. So what is similar in this structure? We can see that absolutely sure the structure will have this ring, yes, and these hydroxides, вот это вот, OH, here and here in this position, after one corner from this big radical. And then also here we have methyl with this OH group again, this hydroxyl, then again one more, and the bigger this radical is, the more affinity to beta receptors the drug has. The less, for example, here in noradrenaline, we don't have this radical, so it will have more affinity to alpha receptors. Here, more alpha receptors. It will block or not block, stimulate alpha receptors. In this case, there is a radical, but it is quite small, so it can affect on alpha and beta. And for example, in isoprenaline, you can see that radical is much bigger, so it can stimulate only beta receptors. The more radical is, the more affinity to beta receptors and less affinity to alpha receptors. Here nothing, so alpha. Here something, so alpha and beta. Here not just something, but a big radical, so only beta. Напишу еще раз. The bigger radical is, the more connection with beta receptors. The more connection with beta receptors, and less with alpha. So this is the rule. The bigger radical is, the more connection with beta receptors and less with alpha. So that is how we understand that noradrenaline works predominantly with alpha receptors, adrenaline with both, and isoprenaline, the drug isoprenaline, stimulates only beta. Okay. Так. Next, role of also the hydroxyl radicals, they play a big role. I told you about these radicals, yes, which are after this amino group CH3, CH3, but also these radicals, hydroxyl radicals, they also play a big role, yes. They are not just like by mistake they put here in these places. No, they really play a big role, and now we'll discuss what is that role. Due to hydroxyl radicals in this benzene ring, catecholamines actually bind to adrenergic receptors. So without them, with a ring only, your drug will have no possibility to bind to the adrenergic receptor. And radicals are substrates for the action of the enzyme catechol or methyltransferase, which will methylate the catecholamines. About this catechol orthomethyl transferase, we talked 2 slides before when we talked about the synapse. Yes, that it can not destroy but change the structure of the catecholamines, which makes them inactive. Okay, which I already told you a piece of information. The ability to stimulate beta adrenergic receptors depends on the substituent near the nitrogen atom. No, this means that radical after the amino group. The bigger is this radical, this substitute, the stronger the drug stimulates beta receptors and weaker stimulates alpha adrenal receptors. So I told you that already. That's why adrenaline equally stimulates alpha and beta adrenergic receptors, because it has the radical, but it is small, only methyl, yes? Noradrenaline doesn't have radical, so it only stimulates alpha adrenergic receptors, and isodrine, which is isoprenaline, only stimulates beta because this radical in amino group is quite big, yes? This is isopropyl radical. Okay, and now what actually happens when we stimulate this receptor? What happens is activation of the enzyme adenylate cyclase if we stimulate beta-1 receptors. This adenylate cyclase is the primary mediator. Then primary transmitter, okay? And then adenylate cyclase stimulates the synthesis of CMP. CMP, this is cyclic adenosine monophosphate, cyclic, from ATP. ATP, you know what this is. And this cyclic adenosine monophosphate activates the enzyme proteinase, which then leads to activation of metabolic enzymes. The metabolic effect depends on which organ in which the effect takes place. So different metabolism changes can be, for example, as we discussed, in the liver. In the liver, it will be increased glycogenolysis. In the adipose side, it will be increased lipolysis, yes. In the juxtaglomerular cells, it will be increased renin production. So different metabolic effects depending on the cell on which we affect. Okay, this all was about the natural norepinephrine, epinephrine, the stimulants of adrenergic receptors. And now we're going to not natural, but synthetic, the drugs, yes, adrenomimetics. They are adrenergic agonists, so they stimulate. It's a group of biologically active substances of natural and synthetic origin, stimulating adrenergic receptors in the body and causing various metabolic and functional changes in the body. So the most important word here is that they are stimulating adrenergic receptors. Yes, my heart for this word. Okay. Oh, sorry. Hearts. So let's now see how these stimulants are classified. Firstly, we already know that epinephrine and adrenaline, epinephrine, which is adrenaline, can stimulate both alpha and beta adrenal receptors. But also we have more selective drugs. For example, stimulating only alpha adrenal receptors. They are norepinephrine, phenylephrine, midodrine. Also we have drugs of alpha-1, yes? Also we have drugs affecting only alpha-2 adrenal receptors, alpha-2 adrenomimetics. For local action, naltrexone, xylometazoline, oxymetazoline. Why for local action, I will tell you, is because they are nasal, they are used as nasal drops. nasal drops for if you have the stiff nose or running nose, yes, to stop this in case of cold. And for the resorptive action, we have clonidine drugs and guanfacine drug, and they effect on CNS. They affect strongly on CNS. Okay. Also, we have selective adrenomimetics, which affect on beta receptors. And beta adrenomimetics, they can be classified as non-selective and selective. Non-selective, they stimulate all types of beta receptors, beta 1 and beta 2 receptors. They are orthoprenolin and isoprenolin. But also we have drugs which stimulate only one type of receptor, beta 1 or beta 2 receptor. And beta 1, it will be stimulating dobutamine drug, and the stimulants for beta 2 receptors, for example, salbutamol, phenysterol. This drug affects mostly on the heart, and this affects mostly on the bronchi. Remember about the beta 2 receptors? I told you that beta 2 is for relaxing. Beta 2 is the relaxing receptors. So these drugs, they will relax the bronchial muscles. Also, we have drugs which are indirect adrenomimetics, sympathomimetics. What does it mean? They are indirect, so they don't affect directly receptors. They work through the accumulation of the natural norepinephrine. So they work through the activation, accumulation of the natural norepinephrine. What does it mean? In this case, norepinephrine will be synthesized in the vesicule, and with the help of this drug, the bigger amount of norepinephrine, I mean, will be accumulated in the synaptic cleft, and it will work better, stimulate the receptors better. So ephedrine, it's the sympathomimetic drug. It doesn't affect directly on the receptors. It just helps our natural norepinephrine to affect more. Понятно? So this is the difference. These stimulate directly receptors, and these don't stimulate receptors. They only help norepinephrine to accumulate more. And so here are the tables with the explanation of when we should administer these drugs, which adverse effects can be. I'm not going to read these tables. You can make a screenshot and read them because actually I think everything is clear here, because I already told you that receptors can be stimulated, and then it depends on where are these receptors stimulated. If we are talking about bronchoconstriction, so it will be relief of bronchospasm. If we are talking about vessels, it will be the contraction of blood vessels, increased blood pressure, so it may be used in the anaphylactic shock, and so on. But of course, it can cause some side effects, some adverse effects, which are cardiac arrhythmia. Also, it can be the presocardiac reflex, which can decrease the heart rate, and so on. So many different side effects. So please make the screenshot of them if you need it. Oh, sorry. That what? So here you can make a screenshot if you need it. Next, the same about alpha-1 receptor agonists, alpha-2 receptor agonists, which can be used for the relief of collapse, for the treatment of rhinitis, as I told you, nasal drops, this, yes. Drugs affecting directly on CNS will inhibit the vasomotor center, by the way, as you remember, and which will be used in the treatment of hypertensive disease. Here also you can make a screenshot. Now, beta receptors and beta agonists. So we have already discussed that beta 1 is mostly located in the cardiac cells, in the heart. Yes, and also bronchoconstriction here can be the indication for these drugs. Bronchi, they have beta 2 predominantly, don't forget. Then sympathomimetic, which doesn't affect the receptors directly, but helps to accumulate norepinephrine. Well, now, once again, let's see how it works. It stimulates the release of norepinephrine from vesicles to the synaptic gate. Then it blocks the enzyme catechol orthomethyltransferase and monoamino oxidase because they will not be able to destroy this norepinephrine, because when it goes outside the cell, there is a risk that it will be destroyed, but we don't want that. We want to accumulate them. That's why we should block the enzymes and stop them, prevent the destruction of our norepinephrine. So it helps us to accumulate this norepinephrine in the synaptic gate, and finally it will stimulate the CNS, stimulate the constriction of the blood vessels, and so on. Stimulate the heart activity and dilate the bronchi. And this all was about the drugs which stimulate adrenoreceptors, but everybody understands that there are also drugs which block adrenoreceptors. So they are called adrenoblockers. They are antagonists to these receptors. We have many situations in which we don't want to stimulate the sympathetic nervous system, and we want to block it, actually, to stop the action of it. To tell you the truth in this situation, living in today's world full of stress, full of difficulties, actually makes our sympathetic system always work. So we are always on stressed out. I don't know. We always have high blood pressure. We always have to work a lot, and our heart is working too much. And that's why actually our problem is overactivity of the sympathetic system. That's why in this case, using of drugs which block the effects of sympathetic system becomes more and more relevant. So that's why we use adrenoblockers quite often. Okay, what can be the adrenoblockers? As we have already discussed in the drugs which can stimulate the adrenoreceptors, we have some selective drugs and non-selective. Non-selective, which don't select actually the receptors on which they will work. They affect both 1 and 2, alpha 1 and alpha 2, yes, if we are talking about alpha adrenoblockers. And the examples are here: phenethylamine, nitsergalin, tropophen. Also, we have alpha 1, more selective adrenoblockers. Alpha 1, they are prazosin, doxazine, terazosin, tamsulosin. They are used in the urological practice in adenoma of prostate gland. And we also have alpha 2 adrenoblockers, for example, yohimbine, which is not actually used in today's practice. Now we are talking about beta adrenoblockers, which can be also selective. This selective, yes, beta 1 only, and non-selective, which block both beta 1 and beta 2. For non-selective, these examples we have. For selective, these examples. And what you can see, that all the drugs which are beta blockers, they end with lol. Лол, пиндолол, тут тоже лол должен быть, lol, lol, and everywhere the same ending, lol. So beta blockers always end with lol, okay? It will be easier to remember if you remember that they are lols. Then, oh, sorry again, beta adrenal. And also we have some drugs which are paradoxically both alpha and beta adrena blockers, which are labetalol, carvedilol, pradoxolol. Here you should make a difference, not confusing them with just beta blockers, because they are also ending with lol. But for your not being very stressed with that, they are only three names here, so it is possible actually to remember them. Okay, now let's see how the adrenal blockers actually affect, for example, on the heart, because for us the mostly widespread disease connected with adrenaline is the heart disease, any type of heart disease, arrhythmia, insufficiency of the how do we call it, like heart failure, yes, ischemia, myocardial infarction, and so on. So all this is connected with the effects of adrenergic drugs. And let's see what happens if we block alpha-1 adrenoreceptors. Давайте посмотрим. By blocking of alpha-1 adrenoreceptors, we have the peripheral vasodilating action. Why? Because alpha receptors are stimulating the contraction of vessels. If you block them, there will be no contraction, so they will dilate. So it will be vasodilating action, which leads to improved perfusion and metabolism of skeletal muscles, decreased hemodynamic load of the heart. This leads to increased left ventricular ejection fraction, and the improved perfusion and metabolism of skeletal muscles leads to decreased cytokine synthesis. Decreased cytokine synthesis, what does it mean? Cytokines, they like bradykinin, interleukin, then maybe serotonin, they are synthesized when in the skeletal muscle there is any problem, and it has, for example, not enough oxygen and it wants more blood supply. So if we have the vasodilating effect, so there is enough blood supply, and our muscles, they don't make cytokines, they don't call more blood. Okay. This all leads to the suppression of myocardial hypertrophy and anti-remodeling effect. Why this is very important? Because anti-remodeling effect, like it makes your heart stay normal, because remodeling is the connective tissue forming in the heart. So we, of course, we don't want that, because the function will be reduced if we have some connective tissue in the heart. And also these drugs have significant antioxidant activity, which suppresses the oxidative stress of the cells, and this all suppresses the myocardial and skeletal muscles apoptosis. So the cells, they will not die. So we can see by this scheme that alpha adrenoblocking, it's not just relieving the high blood pressure, it is also the protection of your heart not to destroy the cells. What is interesting here about the blood pressure? Давайте подумаем. Let's firstly remember, I will show you a thing. We will firstly remember that in the blood vessel, let it be the blood vessel, this drawing, not a drawing class, but I will make a blood vessel for you. Okay, this is blood vessel. And we remember what kind of receptors do we have in blood vessels. In blood vessels, we have predominantly alpha-1 adrenoreceptors, and also we have beta-2 adrenoreceptors. Alpha-1 and beta-2 adrenoreceptors. So what's going on? if we are given adrenaline to this blood vessel, adrenaline, I will show you. Так, сейчас. If I'm given adrenaline, it stimulates firstly this alpha-1 adrenoreceptors, and the function of alpha-1 adrenoreceptors is to contract the vessels. So after giving our patient with adrenaline, we will have contraction of vessels and the blood pressure will increase. Yes. Then after some time, it will again decrease back, and we are given the phentolamine. Phentolamine, what is it? Phentolamine is the selective alpha adrena, no, not non-selective alpha adrena blocker. So it blocks alpha adrena receptors. Okay, it blocks, so the contraction will be less. That's why we can see here the decrease of blood pressure. Yes, it decreases because already no contraction can be, even with the natural adrenaline, contraction will not happen. And then we are given again back, adrenaline. But what happens? Adrenaline now cannot work on these receptors because they are blocked. But it can work on beta-2 receptors because we remember that adrenaline works both alpha and beta adrenoreceptors. That so we remember that adrenaline works on both types of receptors. So if one is blocked and this action cannot be made, but second still works, and actually it was working in the first case also, when in the beginning when we gave, it was also working, but it was not that visible because the effect from alpha was much stronger. But now we don't have effect from alpha because this is blocked, and we have only effect on beta-2, and we remember that beta-2 is always relaxation. And that's why after injecting adrenaline, we have even more reduction of blood pressure because now it works only for relaxation. Is that clear? I hope yes. Okay, and now talking about beta adrenoreceptors blocking, how that can work in our body. Firstly, we discussed that we have several places where beta receptors can work. For example, in the kidneys, in juxtaglomerular apparatus, as you remember, it can reduce the renin secretion, which is showed here. The renin secretion will be reduced. That's why renin, angiotensin, aldosterone system will also be reduced, which stops the norepinephrine secretion. Not stops, but doesn't help. Yes, and this all leads to decreasing the progression of the chronic heart failure. This decreases the beta-1 receptors in the myocardium. This helps to increase the myocardium contractility because when we have more beta-1 receptors, they are less sensitive. And when we have less of them, they are more sensitive. Direct effect on myocardium of beta adrenoreceptors in myocardium will reduce the heart rate and reduce the risks of arrhythmia. And it will also recover the energy potential of the cell and reduce the ischemia. Finally, we have the preventing of the necrosis of the myocardium by the help of all these different methods. So what we can say about this? All the drugs which we study in alpha and beta adrenoblocking block, they are not only helping to reduce the blood pressure, they are also helping to prevent the destruction of the cells of the heart. So they are like security in our heart. because the heart can be affected by many different systems, and if you help it to relax sometimes, not relax very much, but a little bit, it helps the heart to work better afterwards. Okay, this was everything, I guess, that I wanted to show you. Yes, спасибо за внимание. Please enjoy studying pharmacology with me. Thank you very much. We should stop our recording. How to do that?